Good morning, team. It's Wednesday. I'm tired. I'm shiny because I just put on all my serums and my Zit sticker. Last night I had some Zit lotion. Now I have a Zit sticker. I have an erupting adult acne Zit that I'm really working on without trying to pop it. I want to get it before it gets big. So you'll have to just look at this. I wanted to talk about antidepressants, about taking things like, I don't love touting any brand names, but as a gynecologist, I tend to prescribe when I need to for our patients because sometimes they see their primary care, sometimes they see a psychiatrist, sometimes they see a licensed nurse practitioner who can prescribe, and sometimes they talk to us. Often they talk to us, whether they're pregnant or not. And most of us tend to have like our own arsenal of antidepressants that we feel comfortable with. And for the most part, for me, and I think I probably speak for most general gynecologists, Lexapro, Prozac, Zoloft, Wellbutrin, those are kind of the four. Definitely there's a few other ones like Celexa and things like that. I just don't have as much experience, so those are the four that I stick with, and I feel very comfortable prescribing them in the lower doses and when it's a single medication. My rule of thumb to my patients is I'll talk you through what I think I know, and I'll help decide if I think you need it, and I'll prescribe it as long as we're not switching too many times. If we have to switch more than 2 medications, then I think you really deserve to see a psychiatrist who's very well versed in psychopharmacology. And if I have to escalate the dose, same thing. Please go see a psychiatrist. And at any time, I think it's great for patients to see psychiatrists, but many psychiatrists don't take insurance, understandably so. Reimbursements for psychiatrists are dreadful for all of us as doctors, but particularly dreadful for psychiatrists who see one patient an hour, which is why psychiatrists by and large do medical management, whereas therapists, psychologists, licensed social workers will do therapy, where it's talk therapy. Of course, this is not a strict rule. Some psychiatrists still do talk therapy. But by and large, psychiatrists will prescribe and the therapists will talk. I will also talk. I feel like 90% of my day is spent talking and psychotherapy of some form or another, which, by the way, ends up being psychotherapy for me as well, right? Like Freud thought that all of us had to go through it, and I've gone through it partially through therapy, and partially through, I think, helping others clarifies a lot of views for me. When I saw a therapist years ago after my first son was born, Kathy Levinson, you know who you are, she truly saved my emotions, helped our marriage, because I was at a point after my first baby was born where life was really hard, and that was wonderful. So I'm a firm believer in get yourself some form of therapy, though I don't think everyone has to do talk therapy. I think there are multiple therapeutic modalities that are partially talk, partially actual concrete action modalities like CBT, cognitive behavioral therapy, dialectical behavioral therapy, EMDR for PTSD and other things. Plus, there's just completely unrelated to like concrete therapy. When I did my integrative, masters, I say masters because I didn't end up doing the work for the masters, but I did all the classes. That was incredibly therapeutic because we had all kinds of integrative lessons that helped me kind of understand myself in a different way. So to me, that is also therapy. So anyone who tells you it's not, you cry foul. You tell them that I said. But getting back to the antidepressants, there's a role, just like anything else. Like we could sit here and say, we want to be all natural. But once again, if you're watching me on your phone, you're not all natural. If you're wearing clothing, you're not all natural. If you live in a house, drive a car, none of what we do is all natural. So let's all acknowledge that a combination of doing things that are kind of natural, quote unquote, and then Western technology is something we all ascribe to in every single part of our world. I mean, we go to school. School is not natural. We were not meant to go to school. We were meant to subsistence farm. Is that what it's called? I don't even know what we're supposed to do as cave people. We were supposed to kill animals, pick some berries, and I don't even know. Not what we're doing right now. So I think that when patients come to me and want medication or don't necessarily know they want medication, I might offer it to them and suggest it to them. It's a long discussion about, the different choices. I think it's, again, valuable to take something, valuable to see someone, valuable to try certain, other modalities. For example, yesterday, Dr. Katie and I had a discussion about sleep, and I said that every night I take magnesium. Magnesium does have some effect on the brain and on relaxation of the brain and serotonin, and I do feel more relaxed at night. Does that mean it's working as an anti-anxiety exactly? I don't know, but I feel that it does. So I take magnesium every night with my vitamin D3, And as of about 2 to 3 months ago, I started taking CBD oil in the morning and at night. Is it helping? I don't know. It could be placebo effect. But generally, I feel like my life is very frenetic and crazy, and yet I feel not as crazy within it as I might have in the past. So I think some of these things are helping. I also do Transcendental Meditation, but I do it completely wrong. I do not do it twice a day for 20 minutes. I don't have time. I know I should make time, but I don't. Actually, I don't even think I should make time. I just don't have time for that. But whatever I'm doing works for me, which is I use my little TM mantra every night before I go to bed. It's the wrong way to do it, but it works for me. So you have to find what works for you. In addition to that, many of my patients are on medication. I am not opposed to it. If I needed it, if I do need it in the future, I will take it. I don't seem to need it right now, but I would. What I want to kind of focus on is this notion that the minute you start medication, all my patients are like, okay, well, I'll start, but I'll only be on it for 6 months. Or I'll start, but then I'm going to wean. Or I'll start, but. And the answer is, okay. I mean, if that helps you feel better about taking it, then I guess, again, placebo, whatever makes you feel good. But I offer you this. You don't need to start medication already with the eye of when you're going to get off of it. You need to start medication for the purpose of helping yourself heal and helping yourself improve how you sit with yourself, how you feel on a daily basis within the crap that you can't control, right? You can control certain things. Like I can control certain things in my life. I have decided to change the way I work because it's become, again, frenetic is the only word I can use. But between now and January, I can't really control the number of patients who come into my office. It is a crazy frenetic pace. So I have to do within this framework what I can do to sit in some form of peace, whatever you need to do. Now, if that involves medication and you believe that in 6 months you're going to feel better, great. But don't just take it and then assume you're going to wean and that's it. Take measures to help yourself get to that point. And I really urge you, don't put pressure on yourself to have to wean. And I see this time and time again with female after female. They've had babies or they're perimenopausal. Those are the two most common times I put my patients on these medications, right? They've just had a baby and they're feeling very postpartum, either sad or anxious. And this really does seem to help take the edge off in certain patients, not in everyone. And they can be on sometimes very low doses. Let's use Lexapro as an example. The starting dose tends to be about 10 milligrams. Some patients are on 5 milligrams. I'm not even sure that's a therapeutic dose. I joke it's like a Tic Tac. But if it helps them, great. But by and large, they all start going, okay, well, I'll be off in 6 months, right? I don't know if you'll be off in 6 months. If you want to be, great. If you can't be, don't put that pressure on yourself. Again, unless you're doing the work therapeutically to get yourself to that point. And therapeutically can be talk therapy, can be acupuncture, can be meditation, can be getting yourself into a different frame of mind work-wise, whatever it is. Once you're in perimenopause, that's another time where the PMDD, premenstrual dysphoric disorder, or PMS we used to call it, symptoms seem to exacerbate. Many patients will come to me in their 40s and go, I just have that feeling, and I jokingly say, like you're going to bludgeon your family 2 days before your period? Yes, everyone kind of agrees, yes. That kind of angsty feeling is very pervasive and common, and many women might need something. Again, I'm not advocating that everyone take medication because we know it can alter things and have side effects, but I am advocating for everyone is individual and gets to choose. But when these women go on it, they're like, okay, well, I'll go off in a couple of years. Well, the answer is perimenopause, as we know, the P word I talk about, can start around 40, maybe even earlier, and can last up to 10 years, maybe longer. Which means if you're thinking I'm going to stop in a couple of years, you might still be in the midst of perimenopause. Or you might be 51 and on the bridge of menopause. And then you're really going through flashes and sweats, which SSRIs can help with those things. So if you say to me, I have to go off of it, again, I'll never tell you you have to stay on it. But I would suggest that it's not the best time to suddenly stop. So you also know, if you're taking it, that you cannot suddenly stop. You might get away with it and you might be fine, but you might also have certain withdrawal side effects. So if you're going to withdraw, if you're going to stop, you should wean and talk to your doctor about how to wean. Anyway, that is how I feel. That I do think, like anything else, there is a role for all of these things. You should discuss it with your internal medicine doctor, family practice doctor, gynecologist, psychiatric nurse practitioner, PA, whoever is taking care of you. But do not feel the pressure of, I can't take it, I have to take it, I'll never take it, I'll take it for a short period of time. Like anything else, these medications have a role. And please, please avoid listening to the influencers on Instagram who just malign these medications much as they do birth control and make it seem like all of these things are terrible. and they supplant them for things that they're selling, oils, whatever it is, because we don't necessarily know that those things are always good or safe for us either. If those things work for you, I think that's wonderful, especially as an adjunct, great. And instead of, wonderful. But if you need medication, again, there is a role. Please remind yourself as you're watching this, or any influencer, none of us is purely natural. We all have made choices, appropriately so. That is why we live past the age of 50. Our longevity was supposed to be cut off at like 50 to 55. We were supposed to be dead. We go against nature every day, respectfully. Like I've said in one of my prior videos, thank you, Mother Nature, I love you, but screw you, you're trying to hurt me sometimes, and I need to go against you respectfully. We have different end results. You don't want us to be on this earth so much. We kind of choose to be here probably longer than our body was meant to, and that's okay. Okay, everyone have a great Wednesday. I will take this off before I see patients, although I'm going to be wearing my mask anyway, so what's the difference? Bye.